can we change gears again?
Yeah.
Let's talk about sex.
Wonderful.
Okay. I know it's your favorite topic.
It's a fascinating topic. It's so interesting.
So let's talk. I know you're a urologist and you're interested in the whole person, but when we think of urology, we think of pelvic organs. But I want to talk about the brain side of sex, and I want to talk about libido.
Mm-hmm.
Tell me, what on earth is going on with women's libido?
Yeah. So libido, no adults get adult sex education. We get a crappy disease and pregnancy prevention plan when we were younger. We never learn how to talk about it. We watch Hollywood films. We might watch porn. We get a very skewed view of how our bodies actually work. So Sigmund Freud kind of wrecked it for us, as he did many things. And he called libido appetitive, which is a fantastic word. But appetitive means appetite driven. And so if you don't eat, you're going to get more hungry. If you don't drink, you're going to get more thirsty. If you don't sleep, you're going to get more tired. Those are appetitive drives. And he said sex is an appetitive drive. For most people, if you don't have sex, you don't want more sex, right? And so women sit around saying, well, I don't want sex. I guess this is how it is. Now, how our body actually works is the responsive desire is like, no, you shouldn't have sex 24 hours a day because you got to have a job and you got to raise some kids and you got to get some sleep, right? It would be destructive for you to want sex all the time. And there are some people who do have that high appetitive drive and it can be quite bothersome to them. So how our bodies work is we say, you know what, you're focused on other things. If you put yourself in a place to be receptive, to be open, to be surrounded by sexual cues, it's the sexual cues that actually prime your body for saying, all right, let's prep for having some sexual activity. Those sexual cues are going to be different for everybody, but it often means being in a relaxed state, not chasing around trying to get 10 things done, right? Your body needs to be relaxed, to be receptive, to be open, to be able to focus in the present moment, to be focused on bodily sensations, because it's the combination of the sensations in the pelvis and the brain primed together that makes the best orgasm.
Okay. And so clearly then it's a very complicated thing to say why women in the peri and postmenopause are struggling with libido,
Mhm.
because it's clearly not just a purely hormonal thing.
That's right. Yeah, it's complex, right? Because we're complex. We're complex things. We wouldn't want to be otherwise. We aren't bacteria. So sex is biopsychosocial, which means it's a little bit biology, a little bit psychology, how our brain is thinking, and then a little bit about how we're socialized, right? Are you allowed to be sexual? Who's allowed to be sexual? Who's allowed to be sexual more than other people? Like, how are we cultured, right? Who's allowed to have their orgasm prioritized in a sexual event? The biology part is really where perimenopause and menopause kicks in. And I always joke, like, I got into menopause because of sex, because I really wanted to understand when women said, my sex drive went down with perimenopause, menopause, what did the research say? Now, again, because we're complex, not everybody's sex drive goes down in midlife. Some sex drive goes up, probably because they're more confident, they give less shits, they know they can't get pregnant, they're in a partnered relationship that is wonderfully caring and explorative and like sex positive, right? So it is a stereotype to say everybody's libido goes down. Some stays the same, some gets better. But there is a role, again, estrogen and testosterone work in the brain. That's where libido comes from. Multiple areas in the brain too, not just this little box labeled libido in the brain. And so it is more of a myth to say testosterone is the only hormone for sexual desire. I have tons of women, you throw an estrogen patch on them, their hot flashes are done, their heart palpitations are done, they're sleeping better, their mood's better, and the libido's allowed to rise naturally because she's just simply feeling better, right? So it is wonderfully complex, but it is very real if you notice that your sexual function is changing in midlife.
So I kind of feel like I see a number of different, you see patterns among your patients. So I think one of the patterns that I see are people who are very happily partnered. They're very loyal to their partner, but they've got a lot of guilt because they just can't be bothered.
Mm.
I had a lady who, I have to admit, she did make me burst out laughing because she said she'd rather have a warm ham sandwich than have sex. She said she just couldn't be bothered. She was like, just leave me alone. Let me watch my Netflix show. But a lot of women express a huge guilt.
Yeah.
They'll say, I feel so bad for my partner. And sometimes I'll say, well, do you have sex? And they say, oh, yeah, I do. But like, I don't want to have sex
Right.
at all. Or it's uncomfortable. They kind of put up with it
Mhm.
because they feel like that's the thing that you should do.
Yep. Yeah, yeah, yeah. What we call I mean, there's so little research in it, I think, because we don't prioritize women, but this, like, um, duty sex is what they
Mm,
call it, or, you just have to do it to keep other people happy. Now, some people do it out of love, but some people do it out of, like, "I don't want this relationship to end, I wanna prioritize it." So a good sex medicine doctor they're just curious people, right? Because if somebody says, "I don't wanna have sex," that could be 12 different reasons why. Is it because of pain? Is it because you never had great sex in the first place? Or is it because the sex was great, but now really the idea of it, and we have to then think more about dopamine receptors. We have to think more about hormones, right? And then there's the people who simply say, I want to want. Okay. Versus the people who are like, no, I'm not thinking about it. I'm running a business. I got kids. But when I am in that sexual context and I know how to focus on my pelvis and I know how to relax my brain, we have a wonderful time. I just need to prioritize that in my life more than I have been doing. So it's wonderfully complex. There's really help for everybody. The International Society for the Study of Women's Sexual Health, which is a mouthful, but it's the ISHWISH conference. It just happened in Atlanta in the States this week, and they're coming out with exciting processes of care, specifically looking at orgasm. That's kind of we've done a lot more work on desire than we have with orgasm. So that's gonna be the kind of the exciting new thing. I can't wait for them to publish that paper, probably still another year or 2 out from that, but they're starting to talk about in a more scientific way instead of just blowing off like, "Oh, you can't orgasm? Drink wine," right? And instead of like, "No, no, no, this could be biologic, it could be psychologic, it could be sociologic. Let's look at orgasm and how to help women achieve that."
Have you got any resources or, I don't know, websites or apps or courses that you think are helpful for patients?
Yeah, as far as, like orgasm? Yeah. So, a very old book, she's, unfortunately passed, it's by Betty Dodson, it's called Sex for One, and that's really understanding your body, how orgasm works. Becoming Cliterate by Lori Mintz is fantastic. I think that book is still in print. OMGyes.com is a great if video doesn't turn you off and you really, like it's sex is hard, right? Because you can't "Doctor, I have heart palpitations." The doctor can put the stethoscope on the heart and understand that. But when somebody says, "Ah, I don't like sex," you're like, "That's a black box. I don't know what you're doing in there," right? Are you rubbing elbows? So if you want more video how-to, OMG, yes is useful. Make Love Not Porn is amazing for sex education, just normalizing sexuality for normal people, normal bodies. And for people, they have videos and stories of people with ostomies. They have videos and stories of people who are survivors of sexual assault. So really kind of opening up and normalizing sexuality for all people, all bodies, all ages. Because again, that sociology part of biopsychosocial is only certain people are allowed to be sexual. You have to be a certain age. You have to look a certain way. That's all made up. And so really opening that up to everybody. There's a lot of work being done with sexual health and people with disabilities. So, I forget, they were just at a conference I was at, it was like, Clitoral Model. If you go to Clitoral Model on Instagram, they're coming out with a book on perimenopause and sex, and doing a lot with, like, what does healthy, normal anatomy look like? Because probably a whole 'nother podcast episode, but the amount of women who don't know what normal bodies look like because our images have been banned on the internet, and then they go in and they literally have cosmetic surgery to fit a fake ideologic normal pattern. To me, that needs to be talked about. I think education will go a long way into body acceptance.
Do you encourage your patients to like get a mirror and have a look at their body parts?
Absolutely. Yeah, absolutely. It's tough. You do need a mirror for some of these parts. Um, but just in exploring people's discomfort with that idea of like, do you have a problem looking at your elbow? No. Right? Of like, okay, isn't it so interesting that there's a part of your body you're uncomfortable looking at? Wow, what's that about? Where did that come from? So it's even like just exploring that a little bit, and even if you end up never looking at it, just understanding, "Oh my gosh, there's a part of my body that society's told me not to look at." That's super interesting.
One thing that I hear repeatedly from all my new patients is that often their past experiences with appointments to address their symptoms of menopause have made them feel rushed, unheard, and frustrated. As a doctor of 25 years with first-hand experience and understanding the many symptoms that one woman may encounter in her menopause transition, I knew I couldn't do this subject justice in a 15-minute appointment, which is why I've created the menopause appointments, designed to support you on your journey through the perimenopause and postmenopause. This 60-minute session gives you and your doctor the ideal amount of time to understand your concerns, needs, and desires. It gives us time to do a comprehensive assessment, including a full review of your medical history, assessing your mood, your sleep, weight, and libido, and much more. Receive referrals for tests as needed, prescribe suitable medications if required, perform a skin analysis, and leave you with a comprehensive, tailored plan unique to you. This is crafted to help smooth your transition through the perimenopause, postmenopause, and allow you to thrive, not just survive. If you or someone you know is experiencing perimenopause or continuing to have symptoms in the postmenopause, these appointments are for you. You can book an appointment with one of our doctors today. We have clinics located at Forster Speech and Newcastle, and you can book online at youbydrshaunawatts.com.au. When I moved from being a GP in Northern Ireland to being a GP in Australia, I found it incredibly interesting how Australian children are much more comfortable talking about body parts than children in Northern Ireland are.
Interesting.
Very interesting. So it's obviously very culturally driven.
Yeah. I mean, parents are role models, and people always ask, like, how do you have the sex ed conversation with different ages? And for the young ones, normal anatomic words for our body parts. They can communicate better. They can communicate with their partner better. They'll be able to communicate with their doctor better. So with my children, it's just like, if they say something hurts, I'll say, what hurts? Is it your labia that hurts? Is it your vulva that hurts? Is it more on the back? Is it your anus? Is it your rectum that hurts? And, not that they need to get it right, but just me normalizing. There's a lot of different body parts down there. And I think a big problem, going to the doctor is people saying it hurts down there. If they don't get an exam, if they don't know what body part it is, they're usually just given antibiotics for a suspected urinary tract infection, right? And there's so much more that happens to our pelvis than urinary tract infections.
Well, I don't know whether you have the same experience, but I think it's very interesting that whenever you do examine a woman as a doctor, they're always apologizing.
Mhm.
So they'll be apologizing that, they haven't waxed, or they'll be, they just are so apologetic.
Yeah.
And I think that's that's probably a conversation for another day. But, no one apologizes when I need to listen to their chest.
Right, right. I'm
Or
so sorry I didn't clean my ear today.
That's right.
And that you have to look at it.
Yeah, but they're so, and even after you do their cervical screening, or I do an internal examination, they'll always apologize and say, "I'm so sorry that you had to do that. Oh, that must have been awful for you." I'm like, no,
Yeah.
that's my job.
Well, I mean, thanks for calling that out, because I think a lot of people don't realize even that behavior is tied into society telling us that parts of our body are shameful. And we carry stuff with us. I saw a woman, middle age, she was probably mid-60s, and she was there for whatever reason that we needed to do a pelvic exam, and she apologized. And I said, "Listen, I look at so many vulvas that I'll just draw a bell curve, and I'll just tell you where you are on the normal scale, right? Spoiler alert, most vulvas are normal." So she said, "Okay." And so her husband was with her. And I'm like, "Listen, your vulva is completely normal, to the point that your vulva is completely forgettable to me. I will never remember this vulva, right? It's so normal." And she had had an ex-husband, I believe, tell her how abnormal she was and how unattractive her vulva was. And she decided that that person's opinion was the most important opinion, and that she would carry that with her for the rest of her life. And her current husband was like, I told you it's lovely. I told you it's beautiful. Like, can you believe the doctor now? Because I've been telling you this for years." She was carrying this asshole's opinion with her the whole time. And it's like, knowing you're normal matters. knowing that your body's held. But where are you going to find that on the internet, right? It's banned, it's blocked, it's considered vulgar, and I think that's where Make Love Not Porn comes in. And then all of the websites where they actually can show like vulvas are like fingerprints, right? Listen, not all scrotums look the exact same either, by the way, right? Like we're not Barbie dolls. We're not all supposed to look a certain way.
I loved yesterday you and I were looking at that model, and there was some asymmetry, because I've had so many quite young women coming in asking. So in Australia, if you want to see a specialist, you need to get a referral from a general practitioner. So if you want to see a plastic surgeon or a urologist, you need me to refer you. And so they will come to me. I've had probably in the last 6 or 7 years. Definitely have had a few young women who've come in and said, "Look, I've checked it out online. I've looked and I know that there's an abnormality. I'm asymmetrical and I want to go and have plastic surgery." But whenever they're checking out the images, I'm saying, "Okay, well, can you show me what images you're looking at?" One, they're either looking at a very, diagrammatic drawing out of an anatomical textbook, or they're looking at pornography. And again, nothing looks completely normal there either. And it is definitely such a, like, I just think it's so sad that people are going to the lengths of having painful surgery
Yeah.
to
Yeah.
try and have some kind of cosmetic normal.
Totally. I mean, these are sexual organs. There's nerve endings that can be cut. There's, reports of diminished orgasm, trouble with arousal. Labia are erectile tissue. So it is not to be taken lightly that we're going to trim these away. And by the way, labia go away after menopause with the low hormones, and women are horrified that their labia goes away. So I'm like, okay, we spend years wanting to cut it off, and then we spend years trying to get it back. Can we stop the madness, right? And I'm also very aware of women tend to have less money than men. For us to be spending our hard-earned dollars on stuff that at the end of the day maybe we should be spending our money on something else, versus like, I mean, how many people truthfully are gonna be looking at your labia? Now, that said, there's always can be a medical indication if they're long to the point where it's difficult riding a bike, if during intimacy they're getting pulled into the vagina and causing pain. I'm not saying all labiaplasties, like, to do a ban on it. I'm just saying the unnecessary ones that are not covered by insurance because there isn't a medical reason, and for reasons of miseducation, lack of education, a lack of body acceptance, those are the ones where I'm like, it's quite possible all of those labiaplasties do not need to be done.
Yeah, 100%. Another group of women that I see are young women who maybe have only had one or two sexual partners, um, and they also have very painful sex. So dyspareunia, and it's causing they've actually got a very loving relationship, but they just can't really have sex.
Mhm.
Can you talk to what might be going on there for those
Yeah.
women?
So again, biopsychosocial, it can be multiple things. So seeing a sex medicine physician, seeing somebody who can talk through all of that, because otherwise you're just going to, again, be told, just drink a glass of wine, just do it anyways, try using more spit, all of these things. There's always a sex ed component that I always go back to because so many people, and the young people aren't having any better sex ed than we had when we were young, that sex begins by putting a hard penis in an unaroused vagina. That causes pain. Hands down, that causes pain. And even young people with normal hormone levels, if you take an unaroused female pelvis and put a hard penis in it, that vagina is not ready. That alone causes pain. So vaginas, when they have proper blood flow, we have erectile tissue down there just like penis owners do, the vagina will actually lengthen and the cervix and uterus will tip back to make accommodations for accepting something. If you don't have that arousal before you put something in there, it can cause pain. And also, if your brain's not turned on, your brain's like, what is this, a tampon? Like, what are we supposed to be doing right now? Like, you have to tell, for lack of better words, warm up the body. Like, don't go run a 10K without like doing it a little bit before you just do a full out sprint, right? But when society tells us and Hollywood movies tell us that sex starts by putting a hard penis in a vagina without any warm up, that's pain. So I always think about that in young women, like what kind of sex are you trying to have? And is your body warmed up for it? There can be tight muscle issues. There can be basically low hormone issues if you're on oral birth control pills. Your vulva can look, for lack of better words, menopausal because oral birth control pills do tend to block hormones down in the pelvis, especially some of the newer lower dose birth control pills. You can really look like a tight, irritated vulva down there. So sometimes we have to think about other birth control options or adding in vaginal hormones way before you're menopausal. So also the role of the brain, right? Has there been trauma in the past? How's the body image? How is your mindfulness and being able to be present in the moment? So sex really is wonderfully complex, but it takes time to dissect this out. The sex medicine doctors are basically like detectives, right? Second, my friend Rachel Rubin says we're sex detectives. So we've got to figure out what exactly it is. And this is often, it can also be what happens. There are some men, penis owners, with very above average penis sizes. There are some women with very smaller pelvises. Not saying those people shouldn't be together, but to say sometimes the anatomy is a little bit challenging. Nobody ever talks about that, right? So all of that needs to be explored.
We talked about yesterday a little bit about the mismatched libidos. Can you explain to the audience your thoughts on that?
Yeah, yeah. I like to normalize mismatched libidos, or what the experts call desire discrepancy, because what we tend to do is we tend to make the male level of libido the default, and so the woman's wrong no matter what if she's partnered with a man. So if we have a man's libido at like whatever level 0, let's say, if she wants sex less than that, then she's the problem because she has low desire. If she wants sex more than that, then she's the problem because she wants sex more. She has the high desire. So the woman tends to stereotypically be circled around what this default of normal is. And when you look at that, you're like, well, that's crazy, right? How come we never say that he's the problem? Now we do sometimes when she wants sex more, then he's the problem. Instead of saying like no two people are ever perfectly matched on anything. Like my husband likes to floss and then brush his teeth. I would like to brush my teeth and floss. Like we are not matched on anything. And so this like societal expectation that you must be perfectly matched with your partner till death do you part is a complete myth that's really hurting relationships. The stereotype awful story is when the man brings his female partner to the doctor and says she has low libido, fix it. And we're like, can we fix you? Right? Like the loving understanding that not everybody needs to match somebody else. Um, is where I always start, is just normalize it and then normalize that let's stop blaming the woman for her always being the problem.
What about if you have a happily partnered couple? I've had a few of these, probably in the last 2 years, who've come to me and they said, we're actually very happy. Their children are grown up, but we actually feel like we've had very boring sex
Mhm.
our whole lives. We've been together since we were 17 and we're now 50, whatever.
Yep.
Um, any resources or hints or tips of how these people can move forward and have a more enjoyable relationship?
Yeah. Yeah, it's a great question because in medicine, in my career, we spend so much time just getting out of dysfunction, right? Where we're kind of like, "Oh, it's average or mediocre. Congratulations, you've reached the pinnacle." But there's this whole other level of like, what if it could be exceptional? Like, you work out forever and then you're like, "Okay, well, what if there's like a next level of fitness? What if there's a next level of cooking? What if there's the next level of, you know, creative writing?" Right? We're humans. We want to optimize. So really, I love that the conversation is like, "Hey, let's not call it good enough just to not have pain. Let's not call it good enough just to be okay with our sex life. What if there is this optimization?" Um, Dr. Emily Jamea, Jamea, just wrote a book that just got published called Anatomy of Desire. And what I really like about that book is it's answering that question of like, yeah, this is fine. Like, certainly better than all the horror stories I hear, but what if there's the next phase? And people may have heard of what we call the flow state. And the flow state is when you're like really engaged in something that have kind of become a master of, and time stops. Your brain's not thinking of the past or the present. And she basically goes down and knocks out flow state and applies it to sex and what has to be present to really be in flow state with sex, where it is this like transformative, spiritual, amazing thing where time stops. You don't know what country you're in because you're so present with pleasure. So her new book, I think, is fantastic for this. Um, and I hope we're going to get more and more. The Magnificent Sex by Peggy Kleinplatz is another good book. Just basically, she's a PhD researcher, and she was like, "Hey, who has great sex?" And these people emailed her, and then she interviewed all of them. And the most important thing I think about that book is nobody who said they're great at sex and they love sex, nobody said it's because I have spontaneous desire for sex. Because everybody says like, "I just need desire to have great sex." No, most people would say desire has nothing to do with great sex. And her research supported that. If it's, I'm okay to try new things. I'm okay to feel safe and to communicate the need for safety. Safety's horrifically under talked about in playing it the role in good sex. Trial and error, prioritizing time, communication is an absolute must. So it's if you research the people who are having extraordinary sex, you could learn from the pros.
This podcast and any information, advice, opinions, or statements within it do not constitute medical, healthcare, or other professional advice. Information is provided for educational and entertainment purposes only. If you have any health concerns, always consult your doctor.